both ultrasound guide. So, to start a caudal epidural injection under ultrasound, you first have to know the anatomy. So, in the anatomy portion, we already know the anatomy of the sacrum and the sacral hiatus. To enter the sacral hiatus, we have to find out the sacral cornu in both the sides. As we all know, the lamina of the first three sacral vertebrae, including the body, are fused, but the lamina at the level of the S4 and S5, they are open, giving us this opening of the sacral hiatus. Now it is not open like this, it is covered by the sacrococcygeal ligament. Now, let us first describe a little about the anatomy, then I'll be moving towards the procedure. Just 1 second. Okay. So, here all the structures are superficial. So, our main target will not be the curvilinear probe here. So, we'll use the linear probe. Now, to go inside the caudal canal, we have to hold this probe at the midline and we have to see over the spine and the midline, whether we are exactly over the midline or not. Now, to find out the hiatus area, first we have to, just 1 second. Hello, hello, একটু পরে class নিচ্ছি. So, we are actually first screening at the long transverse way or the short axis way. In the short axis way, what we are going to see is this structure. So as we are over the sacroiliac joint, sorry, we are over the caudal space, then we will be seeing in the transverse view the left and right caudal. Now, the membrane covering this area is the sacrococcygeal ligament, and we have to go inside this canal. This is known as the front canal. Now, we have to move slightly up to check whether we are at the right place or not. So what will happen as we move over the S3, the upper table will be closed and this picture, which was previously like this, will be changed like this. So this is an important landmark and we have to consider this before putting the needle because whether we are at the right place or not. Now, as we got the end of the S3, now change the direction. Where we will be changing the direction? We'll be changing the direction to enter long axis view. So once it is long axis view, then we'll be able to see this sacral vein opening like this. Now, this is the upper table, which is the part of the S3, and this is the posterior part of the body of the S4 and S5, and below there will be the coccyx. And above this line is the sacrococcygeal ligament. So this is the view where we have to perform the procedure. Now, while performing the procedure, we have to first give local anesthetic at the lower portion, then we have to enter the epidural needle that should cross this area, okay, the upper part of the sacrococcygeal ligament. Once we are crossing the sacrococcygeal ligament, if you are doing it an ultrasound assisted caudal epidural, you can go further up to the lower border of the S2. But if you are performing a, one more second, please. Hello. বলো 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 So I'm really sorry. And so now we are seeing this area and we have to go up. Now, if you are doing a ultrasound assisted caudal epidural, then we have to go up east. If you are doing a purely ultrasound guided caudal epidural, then do not go that much. Just after crossing the sacrococcygeal ligament, switch on the Doppler mode. So once in the Doppler mode, once you are giving the injection, we will see the fluid is going towards the up. So what's the reason behind? But in the fluoroscopy guided, we are moving up, but in the ultrasound guided, we are remaining at this point. The reason behind it is when we are doing the ultrasound guided caudal epidural only, then there is a possibility that our needle tip might go inside a vessel. If it is above, that we will not be able to see that. But if it is just crossing here, number of capillaries are less, and we'll be able to see that the fluid is moving up. So that is the difference while doing the ultrasound guided caudal epidural. So let us see, this is the central portion. You can see the spines. And once you got this area, then we have to first inject local anesthetic at this point. Then we have to put the caudal epidural needle and we have to cross the sacrococcygeal ligament. So we are crossing the sacrococcygeal ligament. And after crossing the sacrococcygeal ligament, we are in the caudal space. Now this procedure, what I am showing, is done with the using the fluoroscopy as well. So we have checked in the fluoroscopic lateral view. We have gone up to the S2. We have checked the dye distribution as well. After that, we have injected the steroid injection. Okay, usually 80 milligram of the dipomethylprednisolone ml of the local anesthetic taken and rest is the normal saline given to make a volume of 10 ml and that is injected. So that is the caudal epidural steroid injection mostly given for the herniation of the S L45 and L5S1 disc. Now here you can see the video. Yeah. So just check needle piercing going up. Okay. Then definitely for this patient as we are going a hybrid procedure, so we are taking the fluoroscopy as well. Fluoroscopy gives the advantage that there actually you can see the in the fluoroscopy you can see its dye distribution so that you are more sure that you are not inside any vessel. So that was the procedure. Now Dr. Roy will be demonstrating the same procedure. Chinmada, can you start the caudal?
So I will be showing the caudal epidural pin. Okay. Okay. So you can see the slide also. This is Dr. Devjyothi's slide only. So here, what is this? Oh. Okay, you can see the slide, isn't it? So now uh, I will show you the short axis view and long axis view. first let us here you can see the probe in a short axis view where I have placed. Okay, so in this area if I place the probe, then this picture should come. Okay, so what we are seeing here, we are seeing the sacral cornu, these are the sacral cornus, and this is the anterior side of the I mean posterior part of the sacral vertebra, posterior part of the sacral vertebra. Since there is no fused lamina, so this is the sacral hiatus area, this is sacral cornu, and here of course you will see a sacrococcygeal membrane in a short axis view. Okay, so let us see. So I will use a this one, your linear probe only, so that you see the structures nicely. Sometimes we may have to use a curvilinear probe also, but here it is okay to use this probe. So this is a linear probe. I am holding it in a short axis view. Left side of our screen is this lateral side, of course. Patient volunteer is lying prone, it is his left side. So left side is on the screen also, it is in the left side. Okay, so this is the same picture what you are seeing. My probe is placed in a short axis orientation over the sacral hiatus. So what we are seeing, so here we are seeing the, these are the sacral cornu, sacral cornu. This is the posterior vertebral margin. Okay, vertebral body, posterior side of the vertebral body, and here we are seeing the sacrococcygeal membrane. Okay, this is the sacrococcygeal membrane. So between them, this area is the epidural space. Okay, this area is the epidural space. So now if we go a bit up, then what you will see, so here you can see I have moved a bit up, then what you will see, you will see this picture. Okay, when you will see the, this hiatus will not be there, and there will be fused lamina. So this was the sacral hiatus area. Now I am going a bit up, so this is the lamina fused area. Okay, so this is a complete bone and we cannot see anything below. This was the starting point between the sacral cornus, this is the hiatus, and when I go up, so this area is fused lamina. Okay, so I think everyone can understand this. There is nothing to more to show here. So next picture I will show this picture. Okay, so this is a long axis view in the midline. Okay, so you can see this is the posterior fused laminas. Okay, so up to this much is the fusion is there. So this point is this point. Okay, and then the sacral hiatus area, this is the hiatus area, this part is the, this is the sacrococcygeal membrane. So you have to puncture here and you have to inject here. Okay, so this is the posterior sacral vertebral margin of the sacral vertebral body, posterior plate. Okay, so here, so one more thing here, there is something, some concept should be there, that these sacral hiatus, this is like in this shape. Okay, so if you remain in this place, then only in middle of the, at the, if you just go through the middle of the hiatus and you touch the tip, then only this opening is this big. Okay, but if you are not at the middle part, and you are a bit at the sidewise, then also you will have a opening, but this opening will be much smaller. So you while when you find the hiatus, you must go right side, left side, so that you find the biggest gap. Then and of course proximally you will see the spine, sacral spine, rudimentary spine, but still you will see the spine, and you will understand that you are in the midline. And that is midline is necessary for the procedure, because you need more space also, and most of the time you are giving caudal epidural, so it should spread equally both side also. Okay, so here cranial side is left side. Okay, so just putting the probe like this is enough. I'll make it a bit, yeah. So putting the probe like this is enough, okay, to see that gap. Okay, so here you see, so here this is, okay, I'll give it a bit like this so that we can, I'll increase the depth a bit. Okay, so you can see, so I am in the midline. Okay, so what I am seeing, I am in the midline, what I am seeing, so this is the gap which I am talking about. Okay, and this is the last sacral spine. So this is maybe the S3 sacral spine. Okay, so this is last sacral spine, and this is the fused lamina up to this much. So if the hiatus is like this, so this point is this point. Okay, and this is the posterior part of the sacral bodies, all sacral bodies, they are fused, so this is the posterior side. Okay, so this part here we should see the sacrococcygeal membrane. In this area sacrococcygeal membrane will be there. Okay, so your injection will come like this, and you will go up to this much, so that you see the turbulence of fluid when you inject the steroid or local anesthetic. So you should see the turbulence, and it should not go below the bone, otherwise you will not see that if the drug is going inside any vessel. Okay, so you have to come this much only. So this is the midline part. Now as I told, that if I am a bit at the side here, if I am at the side, then what happens? Then you will see this area will become smaller. This area, this is actually mid, okay, this picture has to be midline. So and now I will show you that how it changes. It becomes the area which is empty now, there also you will see the bone, and it will become smaller. So this is the midline. Okay, you can see this much area is the gap, this much big gap. Okay, so from this area to this area, big gap. Okay, and since we are seeing the spine, sacral spine, so we know we are in the midline. Now I am going to one side, so that we will see that spine is not there. Now when there is no spine as such, when we are at the side, then you see the area has become much smaller. So bone is here, also you can see another bone. Okay, here also, this side also you can see another bone. And if you see in the midline, then this side, from here only there is a gap, but if you go to side, then you see bone comes up to here, and this part is so small, this part is so small, you have to be staying in the midline to get a good access. Okay, okay, I will show you some more uh, important views, so that you get an idea of the complete area. This much is important for the sacral hiatus and caudal epidural. But let us see this view also. This is like midline view, when we will see all the small sacral spines. Okay. Then comes second, I will put my probe over the foramen. You will see all the foramens and the bone in between bones. Okay. If I go medially, then this will come, and in laterally again another small part of bone comes. So these areas called, this one is called medial sacral crest, and here it can be another part which is lateral sacral crest. So if you can imagine, if I put a short axis view, then how it will be. This is the part of the sacrum, say this is the sacrum. Okay, I put it here. So this is the part of the sacrum. So if I put a short axis view like this, then first I will see some amount of bone, then I will see a small gap which is the foramen, then again small amount of bone, then spinous process, sacral spines, then of course in the opposite side again small amount of bone, and then foramen like this. Okay, so I show you first the long axis view of the sacral spines. So this is the lower end, lowest end, and then you can see these are the sacral spines, the areas. These are the sacral spine. So why I am showing you this thing? There is a use of that also. See the depth. See the depth. These are sacral spines. Okay. These are sacral spines. So here in this area, it looks like that these spines are similar, all same. Okay, hardly you can say which one is L5 spinous process and which one is sacral spine. It is very difficult. If you are going in middle part, in the midline, so these are also gives nearly similar picture. See, these are sacral spines, these are sacral spines. Okay, these are sacral spines. Okay, so these are sacral spines. This one spine is looks a bit up, which is a bit more superficial. This one spine, others are a bit deeper than that. Okay, but still all are spine. Okay, you cannot say that which one is L5, which one is S1, which one is L4, or which one is S2, like that. Okay, so this also has some value. I will show you. So now first, this is the midline view. Now as I told you, I will show you the foraminal view also. So this is the midline. This is the midline view. Okay. Right. This is the midline view. Now if I see a bit medially, then if I come medially, so this is the medial sacral crest. This is the medial sacral crest, where there is this is the bone area only. Okay, more this is medial sacral crest, as I have come a bit lateral than midline. If I go more lateral, then I will get this picture. So just wait, I increase the depth a bit. So this picture, where small you can see the foramens, which are this is the ultrasound beam is coming down. Here also ultrasound beam is coming down. So these are over the foramens. Okay, when my probe is over the foramens, this is a longitudinal view over the foramens. So these are the foramens. These are the foramens. Okay, these are the foramens. The two foramens, 1, 2, you can see. If I go a bit medially, you can see medial sacral crest. More medially, you will come over the midline. Okay, this is the midline area. So these are different pictures. Now Okay, short axis view I did not show you. So short axis view also I can show you. So this is the, as I told you, so this is the lower part, sacral cornus you can see. This is the most lower part, sacral cornu. And if I go up, so this is the fused part. I go a bit more up. So in this area, you can see fused sacral spine. If I go to one side, then you can see the sacrum, the body, and the foramen. So this is one foramen. Okay, it may be say S2 foramen or S3 foramen. So this is one foramen. Okay, this part is the medial sacral crest. This part between the foramen and the spine, this is the medial sacral crest. This is also important because there are some procedure when the medial sacral crest becomes important, and lateral sacral crest, this is the lateral sacral crest. Okay, so this part also becomes important. Anyway, so this part is done. Now another, just lastly, so I told you, lastly is counting. As I told you that if you are in the midline, then you cannot understand at which level you are. So both sacrum S1 and L5, both spines nearly look similar under X-ray, under ultrasound. But if you go a bit paramedian, then you can count, then you can understand that you are between L5 and S1. So let's see how it looks. Again, the cranial side is left side. So I am going up. So this is the midline part. Now I will come a bit paramedian. So when I am coming paramedian, so these are all medial sacral crest area. Okay. So now I will go up. Now I will go up. So in some portion you will see, okay, I will come like this. So in some part you will see that there is a break. There is a break. So that break is nothing but L5S1 level. Okay. So this is the level for L5S1. Just a minute. Sometimes this probe. So this area, so in this area, here you can see the break. So this is the break, this is the L5S1 space, because in sacrum there is no break. This is a medial sacral crest you are seeing continuously. Okay, this is sacrum, this is the medial sacral crest you are seeing continuously. But here, as soon as you come here, you see this is the L5 spinous process. Okay, so this part is the L5. This is actually lamina, not spinous process, L5 lamina. So this part is a gap between L5S1. So you understand you are at the L5S1 level. If you go up, you can, now if I go medially, I can see, I can understand that I am at the L5S1 level. So I am counting the level at the paramedian portion, then I am going medially to see that, okay, this is the L5S1 level. Okay. Okay, then this much only for caudal part.
Please stop the screen share. Yes.
Yeah.
So let's move to the sacroiliac joint injection. Now we all know sacroiliac joint is a diarthrodial joint which is formed by the articular surface of the sacrum and ilium, which is separated by the joint space. And the joint in the lower portion is synovial, especially in the posterior and the inferior aspect. Superior and posterior joint surface lacks a joint capsule housing an intraosseous ligament. Joint capsule. Anterior joint capsule originates from the anterior sacroiliac ligament, Posterior aspect encompasses the stabilizing ligament like posterior sacroiliac, sacrotuberous, and the sacrospinous ligament. And each related degenerative changes result in the narrowing of the synovial cleft inferiorly, resulting to the fibrous ankylosis. So these are the anterior sacroiliac ligaments stabilizing the joint from the anterior side. If you go towards the posterior side, we'll be able to see the posterior sacroiliac ligament, just underneath which there is the capsule. There are two additional ligaments reinforcing and strengthening this joint. One is the sacrotuberous ligament. This is the sacrotuberous ligament, and the other is the sacrospinous ligament. Okay. So, in between these two ligaments, there is an important nerve as well, that is the pudendal nerve. But anyway, today we are not going into the nerve block. But right now, we are going for the sacroiliac joint injection. Now, we have to know the muscles just overlying the sacroiliac joint. So, we have basically three muscles. They are overlying these joints. First of all, the latissimus dorsi, very small flat muscle, very difficult to identify and within the skin and subcutaneous tissue. But important three muscles lies slightly below. First is the iliocostalis, which lies lateral and superficial. Then is the longissimus, which lies medial and superficial. And deep to the longissimus, we are having the multifidus muscles. So they lies over this area. Now, to see this joint, we have to go from the posterior superior iliac spine. We have to go slightly down. Usually, just below the posterior superior iliac spine at this level, we see the S2 foramina, and this is the level of picture which is seen under the cross-sectional view at the level of the S2 foramina. Now coming to the indications, definitely there are two types of indications. One is the diagnostic to demonstrate sacroiliac joint as the origin of the pain, and is the therapeutic, that is the alleviation of pain associated with the degenerative conditions of the inflammations affecting the sacroiliac joint. I'm really sorry, I'm not able to raise my voice and it's becoming a little flat. Now coming to the contraindications. So similarly, we have the patients reported with the history of the allergic reaction or cortisone injection. Sometimes there is local infection or local malignancy. That is also a contraindication of the sacroiliac joint injection. Now, in the relative contraindication of the ultrasound-guided sacroiliac joint injection is the coagulopathy or the correct recent use of the blood clearing agent. Pregnancy, in emergency, definitely we can go for this ultrasound-guided sacroiliac joint injection, but not for the fluoroscopy-guided sacroiliac joint injection. Then systemic infection, septic joint and osteomyelitis. Definitely wherever there is systemic or local infection, we should avoid unless and until the infection is controlled. Patient with the diabetes mellitus with the history of the poor glycemic control, yes, we have to skip doing this procedure. Advantage, uh, first of all, we can see the better visualization of the soft tissue structure and it can be performed bedside. So whatever the advantage of the ultrasound will be there, and definitely there is no exposure to the radiation. And limitations, one of the biggest limitations that we cannot do the arthrogram, we cannot give the dye, and accidental intravascular injection detection, which is possible with the dye, is not possible in the sacroiliac joint. So to see the sacroiliac joint, we have to focus at this point when we can see the sacroiliac joint. We can see foramens and we can see this area. Okay, so this the area is basically the sacroiliac joint. This is the S2 foramina, this is over the lamina, and this is the spine. So we can see all these structures together at this point. Moving to the next part. So here we can see the isolated sacroiliac joint, and here one of the tips that you have to consider is that use a curvilinear probe. Don't use a linear probe, because what happens if you are using a linear probe, we will not be able to see the echoes inside the sacroiliac joint. So this curve will be less because the linear probe, the echoes will not be coming back under this sacroiliac joint. So you have to, this is the correct needle path and you have to put the needle and then we have to inject. So that was about the sacroiliac joint injection. So I'm just continuing with the rest to the theory part I am covering and then I will ask Dr. Roy to show the sacroiliac joint injection. Then I will demonstrate at the last the other two blocks, that is the celiac plexus and the superior hypogastric. So I'm continuing. with the celiac plexus and the superior epigastric plexus block. Just one second. So these are the another two very important blocks, that is the celiac and superior epigastric plexus block. And nowadays it is being replaced by the fluoroscopy. And in a good number of cases, we are actually doing this block with the help of the ultrasound only. We are not going for the fluoroscopy here. So what are the advantage of the ultrasound? Definitely, the advantage of the ultrasound will remain. It is bedside. You can see the structures, you can see the vasculature, you can see the needle, you can see the drug distribution, which is not possible with the help of the fluoroscopy, but lacking the advantage of the contrast distribution that will remain. Now coming to the celiac plexus block indication, it is indicated for the upper abdominal cancers, chronic pancreatitis, and the evidence in chronic pancreatitis is 2B. Now, we all know the splanchnic nerves coming together, they are piercing the diaphragm, are coming to the anterior side of the aorta, around the celiac trunk, and they are forming the celiac plexus around it. Now, it's a large ganglion, so ultrasound use of radiofrequency block is not possible because radiofrequency gives a lesion size of 2 to 4 millimeter, but the gland is a large sized plexus. So, the only way we are left with is the neurolytic agent. So still in these two areas, that is the superior epigastric plexus block and also in the celiac plexus block, we have to go for the neurolytic apart from the radiofrequency. Though some studies are there with the pulse radiofrequency, but with the conventional radiofrequency, it is not possible to cover this much of area. So we have this celiac plexus, we are having the celiac plexus now divides into two branches. One is the common hepatic artery and the other is the superior splenic artery. So you can see this is the common hepatic artery that is going towards the left side and other is the splenic artery. But remember, there is another artery as well, that is the left gastric artery, but it is small and very difficult to look at. So you will be mainly seeing the celiac plexus which is moving, taking the blood up and it is dividing into left and right side. If you are accidentally slightly below from that area, you will be able to see a superior mesenteric artery. So this is the superior mesenteric artery. So in case you are able to see the superior mesenteric artery in front of the aorta, you have to move up at this area. Now, types of celiac plexus block. So it depends on where you are injecting. If you are behind the crus of the diaphragm, that is the retrocrural. You are anterior to the crus of the diaphragm, that is the anticrural. If you are at the level of the vertebra and we are around the T11 and the T12 vertebra, that is the splanchnic nerve block. Now, here we cannot go for this retrocrural and the subsplanchnic nerve block with the help of the radiofrequency, with the help of the ultrasound. In ultrasound, we are going anterior part of the aorta. So ultrasound guided celiac plexus block are always anticrural. So this is the structures around. So right side there is the liver, left side there is the stomach, and below we'll be able to see the aorta. Just by the side we'll be having the IVC and portal vein. And this is the division that we need to look at. So first scanning should start from the xiphisternum and we have to go down from the xiphisternum and we have to first look at the structures in a short axis view. And the short axis view, usually this picture is initially located. This is having one-sided, this is the IVC, and the other side it is having the aorta. And just below we have the vertebral body. So we have to locate this area. That is very important. Now this is the IVC and this is the liver and this side it is the aorta. So once we have located aorta, then we have to move up and down or we have to go slightly up and down to see where is the celiac plexus. But before that, if you are not getting it, you can check in the longitudinal direction. In the longitudinal flow, you can see these three arteries. This is the superior mesenteric artery, this is the aorta, and this is the celiac plexus. So that is we have to find in the longitudinal orientation. Now, if you are just above the celiac trunk, then you will be able to see that common hepatic artery and splenic artery splitting in both the sides. Now, this is known as the seagull sign because it looks like a bird. So you can check with the color as well. So in the color Doppler, you will be able to find out this. But remember, if the patient is taking respiration, it is very difficult to focus and keep the focus always on here. So you can ask the patient to hold the breath if required. Similarly, this is the picture with the color Doppler in the longitudinal view. And we have to inject just above the seagull in the transverse view, or in the longitudinal view just we have to go anterior to the aorta. Remember, it is some said that is it essential to go just above the seagull? That is the answer is not. We have to close to the anterior part of the aorta where the celiac trunk is originating, because we are injecting around 20 to 40 ml of the liquid, and that will going to sprayed in this area so that they will cover the whole of it. So going to the right place is important. Now coming to the complications, if you are not able to do it perfectly, there are chances of bleeding, retroperitoneal hematoma, there are chances of the pneumothorax, chylothorax, and impotence, paraplegia, intravascular injection, infection, thrombosis or embolism, intrathecal or epidural injection, hypotension, diarrhea. So while doing under ultrasound, be again and again sure you are seeing the tip of the needle, because if you are not perfectly seeing the tip of the needle, you might go into the wrong place. Now, coming to the superior hypogastric plexus block. Now, superior hypogastric plexus is a continuation of the all three sympathetic ganglions, like the preaortic, the renal, as well as the celiac plexus. So all three continuing, and they are coming in front of the L5 vertebra, and they are forming the superior hypogastric plexus, from where the left and right hypogastric nerve they continues below, and they forms the ganglia which is known as the inferior hypogastric plexus, which is situated from the posterior to anterior side within the pelvic organs. So it is very difficult to block the inferior hypogastric plexus solely, so we more rely on the superior hypogastric plexus now. Now, indications: pain that is originating from the bladder, urethra, ureter, vagina, vulva, prostate, penis, testis, rectum, descending colon, perineum. Pain may be secondary to the cancer, which can be metastasized in the penis, cervical, prostate, testicular, colorectal, etc. Endometriosis and radiation injury. Now, to see the anterior portion of the fifth lumbar vertebra, we have to check the bifurcation of the aorta. So, left and right common iliac vessels, when it is bifurcating just below it, we have the fifth lumbar vertebra. Remember, here one thing is very important. Usually, the arterial bifurcation occurs first, and then the union of the left and right celiac vein occurs. The left and right common iliac vein occurs. So, usually, the left common iliac vein crosses over to the upper part of the L5 vertebral body to reach the right side to form the IVC. So you have to come slightly down at the frog sign. When you will be able to see the frog sign without any vessel in between, we have to put the needle just anterior to the fifth lumbar vertebra. Then you have to inject around 10 to 20 ml of the neurolytic, and then you have to take the needle out. So that is the procedure. Complications includes bleeding, especially into the retroperitoneal space, puncture of the surrounding organs, nerve injury or paralysis, puncture of the adjacent vessels, and distal ischemia. So this is the picture. That's what I am telling. So you have to come at this area. So you have to first see the bifurcation, then come down at this area, then we have to inject. So that was the theoretical part of it. So if you have any question, I'll answer, or Dr. Rao will start demonstration of the next part. No questions. Chinmada, can you start?
Yeah, just a minute. Actually, my in internet was not there. I'm just rearranging the things. I hope there will be no electrical power off or something like that. It's raining too heavily. Just a minute. So I am audible?
Yes, sir. Audible.
Too much rain and lightning is going on here, so hope nothing happens. I'm doing fast. Okay. So uh, so here one important thing here, just you see that okay. So we all know that this is the sacroiliac joint. Oh, somebody is talking. Somebody is okay. I muted. Anyway, so thing is that this is the SI joint. Okay, this is the SI joint. Think that this two bone has been taken out. So only the yellow part is the joint. Okay, other part is not the joint. It is the overhanging part. When these iliac bone is hanging over, just it is making a shadow only over the sacrum. So this part is this red part. Only small part is actually the joint. So here also there is some importance. First we will see at this point, okay, upper one, when we will see the posterior superior iliac spine. We will try to see the posterior superior iliac spine. So here if I put my probe in a short axis view, then I will see the iliac bone hanging over the sacrum. So you can understand this will be more superficial and this will be deep. So at this area, actually this red part is accessible, but this is not the joint. So we have to come down where both the bone is at the same level or at nearly same level. And at when you will see both the bones are nearly at same level, then you will see medially this foramen also. This is S2 foramen. This is S2 foramen. So in that area only you will, if you inject in that area, then you will enter in the actual this yellow portion, which is the real joint area. Okay. So just see. So first part, as I told you, first part I will show. Here the iliac bone is much higher and this is the sacrum part. Of course, this one is S1. This is one is S1. You can see it is going just over the S1. So here if you inject, you will actually go in the ligamentous part. Okay. So you have to come a bit down. Where you will come? Just here in the lower part, where both the bones have come in the same line. So here actually this part is ilium, this one is SI joint, this one is S2, no sorry, this one is SI joint, this side is ilium, and this one is S2 foramen. Okay, so I am showing you both the pictures. First we will search the posterior superior iliac spine. We will use the curvilinear probe, because otherwise we will use both the probe just to show you clearly, but still at present I am starting with the curvilinear probe. So here left side is lateral side, left side is lateral side. So posterior superior iliac spine you can palpate also. So I am just putting it and I can see this is the posterior superior iliac spine. This is the posterior superior iliac spine. We know that this is part of ilium and it is hanging just covering the sacrum part. So this part has to be the sacroiliac joint. Okay, this side is gluteal side, we know, and this side is posterior superior iliac spine. So at the first instance we know that okay, this bone has to be the, this bone has to be the sacrum. So at this point, what we will do? So we know that in this area, if we see, so in this area, what I am seeing, that this is just under the ligament. Where is the sacroiliac ligament? This white line is the sacroiliac ligament. This white line. Okay, sacroiliac ligament. Anyway, so this is the first point you have seen. So this is your midline of the sacral spine. Okay, and this is the sacral lamina, and this part is covered by ilium. So now I am gradually coming down. As soon as I have come down, so you can see both the bones have come at the same level. So this is the last part of sacrum, ilium. This is the ilium part. This is the sacrum, and two areas you can see. These areas also there is a gap because ultrasound beam is going inside, and this area also there is a gap. Ultrasound beam is going inside. So this is the S2 foramen and this is the sacroiliac joint. Okay, clear? This is SI joint and this is the S2 foramen. If I go up, then you will see the S1 foramen also. So this is the S1 foramen. This is S1 foramen, and here also sacroiliac joint looks like that it is sacroiliac joint between sacrum and ilium only. But here if you inject, you will go just under the ligament. And this is S1. When it comes down at the same area, I mean same level of the both the bones. So this is the actual SI joint and this is the S2 foramen. Okay, this is the S2 foramen. So if you want to see more clearly by the overlying muscles and all, then I can show you by linear probe. Okay, so these are the linear probe. So here you can see it is the midline, sacral spine, sacral lamina, and I am going laterally. So our always ultrasound start from the sacroiliac spine, posterior superior iliac spine. Okay, so I am coming from up like this. Now this one is the posterior superior iliac spine. So these posterior superior iliac spine, as soon as I have found, I will go see medially, and I know that this is the sacrum. So this part has to be the sacroiliac joint, this part. Okay, so now I will try to make both the bones at the same level. As soon as I make at the same level, here a bit difficult to see because it is linear probe. So you will see like this only. So this is the area where it is the actual sacroiliac joint, and this is the S2 foramen. This is S2 foramen, this is sacroiliac joint. But here the beams will not go inside because this is not a curvilinear probe, so beam is not going in a angulated direction. So this is the sacroiliac joint, this is S2. Okay, if I go up, I will, this is S1, this is S1. Okay, and this is the sacroiliac ligament. This is the sacroiliac ligament. This part. Wait. No. So these are all muscles. These are paraspinal muscles. These are all paraspinal muscles. Okay. Anyway, so this much only in the SI joint part. Anyone has any confusion regarding the SI joint? Anyone has any confusion?
No, sir.
Or everyone has, yeah, understood, no? How to find out the SI joint. So posterior superior iliac spine, then try to see both sacrum and ilium on the same level. Then you will see the joint also and S2 foramen also. That is the area where you should inject. Okay, then stop share. Devjyoti? Yeah.
Am I audible? Hello.
Yes, yes, you
Yes.
are audible.
Yes.
Yes, audible, audible.
So today, just 1 second, I'm reducing the echo. Okay. Now think I am audible. Echo is there or gone? Still is it echoing? No. I think okay.
Echoing, but a bit less.
Okay, just
Still
1 second.
echoing.
Okay. What happened? Okay. I think now it will be fine. So unfortunately today I will show the area, but today the vowel is not clear. So there is a possibility that the celiac plexus, the division cannot be seen very clearly. Okay, so in that case, we'll send a recording from the previous classes. Because in ultrasound guided celiac plexus block, there is a very important to clear the vowel. So here for this patient, definitely for volunteers, it is not possible to give the laxatives and then doing the procedure, because we have to make the bowel clear, then it will be picture comes better. So I am just holding the probe at the level of the xiphisternum. Just 1 second, I have not started transmission. 1 second. So I think now you can see it. Okay, fine. So I am adjusting my probe. Okay, sir. So I am holding it from one side so that you can see the probe from the other side. So if you have any problem in seeing the probe, just let me know. Okay. Okay. Can you see this? The abdomen is clear. I think you can see that clearly, the abdomen. Now, what we are doing, we are first holding the probe at the level of the xiphisternum. So you see, this is at the level of the xiphisternum. No, from this side, it is almost impossible to see the probe. Let me change the position of the camera. হাতটা একটু সরিয়ে দাও, হাতটা একটু সরিয়ে দাও, হাতটা একটু সরিয়ে দাও, হাতটা কোন থেকে সরিয়ে দাও, পাশে করে দাও, পাশে করে দাও, করে করে দাও, ওকে। I think now you can see it and you will be able to see the probe as well. So I am starting the scanning from the xiphisternum. Now here you can see artery and vein along with the vertebral body. So this is the first structure that we need to identify. Let us show you which one is which structure. So can anyone tell what is this structure? Please, someone speak out.
Vertebra.
Yes, this is the vertebra. And what is this structure?
Aorta.
Aorta. What is this structure?
IVC.
IVC. What is this structure?
Liver.
Liver. Fine. So we got
Liver.
to know the most important structure. And this side, it's the stomach. So it has the food, gas. So we can see the gas shadows. Okay. This side is not clear. Now, so once we got this picture, we have to start scanning with the probe. You see, fortunately, I got a very good window. So at this point, can you see some gush of blood is moving up from this area? See here at this point, I am taking it away so that you can see. Can you observe with the respiration, it is moving, but some gush of blood is moving up and then it is dividing into the left and right side. Now I think I am able to stop at the correct position. So let me draw with the pen. So this is the aorta. You see, from here there is a vessel. Okay, so that is the celiac trunk. Now it is dividing into this branch, and this branch. Okay, so these are the lines, basically two branches, left and right. So everyone can see this picture. So fortunately, I got a very good window. Everyone can see this picture. The division.
Yes.
So this is known as the Seagull sign. So usually we take it as a wing, and this is another wing. So this is the Seagull sign. So once we got the seagull sign, everything is easy. Just go at the top of the seagull. From left or right side, you choose what structure you want to puncture or prefer to puncture. It's the stomach or the liver. Definitely, you have to puncture one of the organs, and then you go at the top of the seagull and then inject 20 ml of the neurolytic, usually 90% ethyl alcohol at this area. Okay. Before injecting ethyl alcohol, always remember to inject 4-5 ml of the local anesthetic, that is the lignocaine, usually 1%, and followed by the injection, because neurolytic alcohol is very painful. When you are injecting, there is burning sensation. To avoid that, you should do it. And another thing, you should also remember that while doing this procedure, you should, before taking the needle out, you inject a very small amount of the local anesthetic or normal saline to avoid spillage of the lignocaine within the tract, and then you take out the needle. Another very important thing is there is possibility that there could be possible infection. So for that, you have to take the care of the bowel, and also in this procedure, we routinely put the patients on an antibiotic. Okay, so this is the celiac plexus block. Now we can see the structure. Okay, so here we can see now with color. Okay, so you see it is, with the movement it is sometimes a little difficult, but now you can see they are taking color. Okay, so above is the superior mesenteric and the hypogastric, and below is the celiac trunk. Okay, so just increasing the gain slightly. Okay, so that is the area where we have to block. Okay, it is not very good. I am not going to take much time on putting the color. Now let us see from the anterior posterior, the longitudinal view. In the long axis view, we can see all the three arteries. See, so this is the, let me check, stop and check. So I told you there are a lot of gas shadows for which a little bit difficult to see for this patient. So let me stop and show. So from this point, you see one blood vessel is going down. So this is the aorta. This blood vessel is the superior mesenteric, and this blood vessel which is coming is the celiac trunk. So from this view, we can see this area, but unfortunately here we cannot see very clearly because of this stool shadow. Okay, that is the transverse colon which is filled with stools. That's why the below portion is not very clear. Okay, so I think you have understood the celiac plexus block under the ultrasound. Any questions regarding it? Another thing, if we want, we can do here. Definitely, it is not very clear, but at least good enough to do the procedure. Okay, so we can understand where it is actually taking origin. So once the bowel is prepared, then this shadow won't be there. Then everything will be much clear. So see, now three vessels are very, very clear. Let me give color that, yes, slightly gain down. I will distract too much. Okay, so we can see this is the superior mesenteric you see, and just above it is the celiac trunk. Anyway, it is not very good. I am not going into again and again for this color, but you can see the superior mesenteric as also as the celiac. Okay, now move to the superior hypogastric plexus block. So let us start scanning. It is usually close to the umbilicus, though umbilicus is not a fixed point. But if the patient is usually having the good physic, you will find it close to the umbilicus. So here at the umbilicus, we can see a vertebral body, and here we can see aorta and IVC. Okay. So again, you have to sometimes do with the gas shadow. So I have removed the gas shadows. Here it is easy because you can put pressure and the gas will be removed to the other places. So now I think you can see the structures. So let me mark and ask. So what is this structure? Vertebral body. What is this structure?
Aorta.
Aorta. And what is this structure?
IVC.
Okay. So as I am moving slightly down, you see from the single aorta, now it is dividing into two. So here is the IVC, but aorta started dividing into two. Clear? This is one and this is another. So we can see aorta started dividing. Go further down, then we'll see some vessel below these aortas. See, there is a vessel going below this aorta. This is the left common iliac vein going towards the right common iliac vein. Now I am going further down. Okay. Once I am down, I am very close to the umbilicus. That's why the air gap is coming. I have now gone below the umbilicus. Now you can see clearly the frog sign. So there is nothing over the L5 vertebral body. Here are the left iliac vessels. Here are the right iliac vessels. So we have a clear area above this vertebra. So here you can see the imaginary frog as well. So this is one ear of the frog. This is another ear of the frog. And this is the mouth of the frog. So we have to come at the top of it. And at the top, you can come either from the left side or right side. And then you inject the drug here. Drug means here usually neurolytic 10 to 20 ml. And here also we can use the alcohol 90% or we can use the phenol 6%. So in the celiac also you can give the phenol. The problem with the phenol is that the duration of pain relief is slightly less than the alcohol. And there is another advantage with phenol is that phenol is having itself an analgesic property. So you do not have to give analgesic while doing the phenol block. So that is one of the biggest advantage of phenol. But disadvantage is that it is having the less duration of action. As well as while injecting phenol, you should be careful that the phenol should not spill over to the patient's skin because it can cause skin burns. So before injecting, first take a needle with the leer lock so that it is not accidentally slipped. Check the needle, it is, should be perfectly joined, and use the saline soaked gauze over the patient's skin so that even if accidentally it spills over, it will not cause skin burn. So once you are done with the phenol injection, inject a little bit of the saline and then come out. So that is how you'll be doing either a phenol or the alcohol neurolytic block. So I think now it is clear the celiac superior hypogastric with the ultrasound. Any questions you can ask me? No questions. So I think we have completed this part, and definitely we should progress forward.
Yeah, I think nothing more.
So initially I thought the division won't be clear because of this tool shadow, but fortunately we are able to demonstrate it clearly.
Yes, 21.
Okay.
Actually, Deputy,
Yes.
today is the last class. And last class means 28. One class is there. Last evaluation and discussion with the participants. So nearly we are coming to the end. Okay.
So next
If-
day, I think we'll be sending you how to go for the exam and the details as well. Okay.
Yeah, and if you have any question and all, ask us in the next class. Okay.
Okay.
Okay, sir.
Okay.
Let's
Thank you.
bye-bye today.
Okay.